Mango Yesu kemabe idima choda. Mango Yesu kemabe idima choda. Idima choe di macho di machoda di macho iti machoe di machoda di macho iti machoe di machoda di macho iti machoda. Every time feel the spirit moving in my heart, I will praise. Every time feel the spirit moving in my heart, I will praise. Da 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 da. This is the story of a brother who slept and woke up in forever land. He looked around, nothing familiar. He wondered how he got to be there. Oh, he took a walk around the city and saw this brick house with a small door. Walked into the room and saw a man in white. Must be an angel, so he said, Mr. Angel, I'm a stranger and don't know what's going on. The last thing I remember was I slept last night. This is the body town that takes you where you gotta cry. Must have heard of heaven where you came from. Only those whose name are find written in this book of life will forever be in paradise. Is your name in this book of life? Is your name in this book of life there? It's your name in this book of life. It's your name in this book of life, yeah. It's your name in this book of life. It's your name in this book of life, yeah. It's your name in this book of life. It's your name in this book at the gate, a cursory gaze. He saw the names of prophets, saints and martyrs, those who kept the faith and won the race. But he said, Mr. Angel, where is my name? Can you tell me what is going on? I'm a pillar in my local church, give the offerings and the tithes, feed the poor and have myself a good name. Is my name in this book of life? Oh, is my name in this book of life? Well, is my name in this book of life? Is my name in this book of life? Unforgiveness lurks within your heart. Some folks that you would never let go. Little foxes and secret folks will spring surprises on that final day. Oh, so much for this wonder, brother. What about you? What about me? Is my name in this book of life? Oh, is my name in this book of life? 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 Thank you.
Thank you. Good evening, ladies and gentlemen. We are starting this evening's program. Shall we please be on our feet as the speaker and the chair take the high table? Respectfully, I ask that we put our mobile phones on silent. Thank you.
I will have to begin by expressing sincere apology for the program starting slightly later than advertised. Good evening, ladies and gentlemen. This is the inaugural lecture to be delivered by Professor SAMPANE-DONKOR. I'll proceed to give brief remarks and then introduce the chairperson for the program. My name is George Obiaje, Assistant Honorary Secretary of the Academy. President of the Academy, past presidents of the Academy, vice presidents of the Academy, fellows of the Academy, distinguished guests, students, ladies and gentlemen. On behalf of fellows of the Ghana Academy of Arts and Sciences, Ghana's premier learned society, I warmly welcome you all to this evening's inaugural lecture on the topic, Prioritizing Antimicrobial Resistance Needs in Ghana, a National Choice Between Life and Death. Since the year 1973, newly elected fellows of the Academy have had to deliver an inaugural lecture on a topic of their choice. This lecture is delivered before other fellows and especially before invited guests such as your good selves at a special event like this one in a way and manner that is not beyond a comprehension and experience of non-specialists in the subject area. This evening's program is one of such occasions when the Academy affords a fellow the opportunity to deliver his or her inaugural lecture since being elected fellow of the Ghana Academy of Arts and Sciences. So we are very pleased to also inform you that in order to expand the reach of the program, this program is being streamed live via Zoom, Facebook, and on the Academy's YouTube page. We recognize the presence of dignitaries, invited guests, and participating schools, and at the right moment, we shall recognize you all. So at this juncture, it is my honor and duty to introduce the chairperson for the program. Our chairperson for this evening's event is Emerita Professor Isabella QUAKYI, Vice President of the Sciences Section and Member of Council of the Ghana Academy of Arts and Sciences. Professor QUAKYI is a professor of immunology and parasitology at the University of Ghana. Her groundbreaking research on malaria immunity and vaccine development at the National Institutes of Health and the New York University in the USA in the 1980s led to the very first approved human malaria vaccine. That is the RTSS vaccine. Professor Isabella QUAKYI is also a fellow of the African Academy of Sciences, and she is the first Emerita professor in the sciences at the University of Ghana. She established the immunology unit of the Noguchi Memorial Institute for Medical Research, 1980-1983. She was the first female director and foundation dean of the School of Public Health, University of Ghana. Professor QUAKYI has earned numerous awards and recognitions. I will just list a couple of them. She has been awarded UNESCO Chair for Women in Science and Technology in the West Africa region. She is the 2014 laureate of the African Union Kwame Nkrumah Award for Women in Science, the 2019 laureate of the Clara Sovmead Ladlo Award of the American Society of Tropical Medicine and Hygiene. And based on her long-standing and groundbreaking scientific work, in the year 2021, Professor QUAKYI was awarded with a recognition by Women's World Day as one of 7 women in science who have changed our world for the better. So with a round of applause, Let's welcome our chairperson. Thank you.
Good evening. Assistant Honorary Secretary, thank you very much for the kind words. President of the Academy, past presidents of the Academy, vice presidents of the Academy, fellows of the Academy, distinguished guests, specially invited guests, our cherished students, members of the press, all protocols observed, ladies and gentlemen, good evening. Now, my role today is a simple task, that of introducing our speaker for today's inaugural lecture. But I must tell you what a challenge it has been getting our speaker to settle on a date and a time. Our lecturer is so nationally and globally sought after that no sooner we settle on a date for him to talk than he's off to collect another award. We finally settled on the date today. His academic excellence and scholarship is quite evident from the collection of degrees and titles. So our speaker is no other than Professor Eric SAMPANE-DONKOR. And then I'll give a brief profile. This is a brief profile. Eric SAMPANE-DONKOR, and this is a list of his titles. Bachelor of Science Honors, Graduate Diploma, a Master of Science, a PhD, an MBA, an MPhil, another PhD, and he's a fellow of Ghana Academy of Arts and Sciences. He's a FIBMS and a FRC Path, and a list goes on and on and on. But he is a professor of bacteriology and global health. Currently, he is the head of the Department of Medical Microbiology, the University of Ghana Medical School, and the director of the West African Research and Capacity Building Program in Antimicrobial Resistance, which is funded by the National Institutes of Health, NIH, in the USA at the University of Ghana. He has 2 PhD degrees, yes, obtained one from the London School of Hygiene and Tropical Medicine, UK, and the University of Iceland, Reykjavik. I hope I'm pronouncing this right, in Iceland. And these are in medical microbiology and public health, respectively. He undertook postdoctoral training in microbial genomics at the University of Cambridge, UK. With a broad academic background, Professor SAMPANE-DONKOR applies concepts from several fields to help address the global infectious disease challenge through research. His current research interests focus on understanding the dynamics of infectious pathogens in at-risk populations. He is considered a high-level expert on the pneumococcus, an infectious pathogen that causes severe diseases such as pneumonia and meningitis. His work on this pathogen contributed to the introduction of the 13-valent pneumococcal conjugate vaccine in Ghana in 2012. And it earned him the first African prize of the Robert Austrian Award in Pneumococcal Vaccinology from Pfizer Pharmaceuticals in the USA. He has researched extensively on antibiotic resistance in Ghana, providing timely data for empirical treatment of bacterial infections in the country and for developing policy documents such as Ghana's National Action Plan on Antimicrobial Resistance. Overall, Professor SAMPANE-DONKOR has authored 142 articles, mainly in international journals, of which he is the first and/or senior author of 75. Within the last 5 years, he has received research funds to the tune of about $11 million US dollars from several funding agencies. And all these as either principal investigator or co-investigator. Between 2022 and 2023, the National Institutes of Health in the USA competitively awarded him 3 major grants, an R01, a D43, and UE5, for a total period of 13 years as a principal investigator. The R01 project, termed the Pneumocystis Study, seeks to unravel the impact of vaccination on the population biology of the pneumococcus in Ghana and identify candidates for a more improved vaccine against this pathogen. The D43 and UE5 projects, which are training programs, seek to establish a core of West African scientists through PhD and postdoctoral research fellowships to tackle infectious diseases in the sub-region. Professor SAMPANE-DONKOR provides consultancy services to several local and international institutions. In a 2020 to 2021 assignment, he led a nationwide study for the Ghana Ministry of Health towards a public-private partnership in diagnostics as part of the African Health Diagnostics Platform. Now, this study formed the basis for assessing Ghana's share of a 76 million euro loan from the European Investment Bank to 4 African countries, naming Ethiopia, Ghana, Rwanda, and Ghana. This is to improve diagnostics in the sub-region. He has served as an academic editor for several journals, such as Frontiers in Tropical Medicine and PLOS ONE, and he is the current editor-in-chief of the Journal of the Ghana Science Association, which is Corpus Indexed. Professor SAMPANE-DONKOR has been a visiting faculty to several international institutions, such as the University of Copenhagen in Denmark, University of Sussex in the UK, and University of Minnesota in the USA. He has been part of several international initiatives, just a few, such as the Fleming Fund convening of antimicrobial resistance experts, Global Pneumococcal Sequencing Consortium, and the Global Bacterial Vaccinology Network, BACTI-BAC. Now, in recognition of his contribution to science in Ghana, Professor SAMPANE-DONKOR was elected to fellowship of the Ghana Academy of Arts and Sciences in 2021. Subsequently, in 2022, he was inducted as a fellow of the Royal College of Pathologists, getting the FRC path in England. This is for his outstanding research and contribution in medical microbiology. Furthermore, in 2023, he was endorsed as an exceptional talent in infectious diseases by the Royal Society UK, the world's oldest learned society. Professor Eric SAMPANE-DONKOR is a member of the Deeper Life Campus Fellowship. He is married to Gloria SAMPANE-DONKOR, and they have 5 daughters, Rochelle, Lena, Micheline, Shirley, and Johanna. And a link to his complete CV is attached, if you are so inclined to go through all. So, Professor Eric SAMPANE-DONKOR, your audience, your speaker for the night. Thank you.
Thank you, Madam Chair, for those kind words. We give all the glory to God as well. So, this evening, I'm going to deliver my inaugural lecture on the title, Prioritizing Antimicrobial Resistant Needs in Ghana, a National Choice Between Life and Death. So, considering the kind of audience here, I think it will be prudent to keep the scientific language very basic, so that everybody will enjoy the lecture. Right. So the lecture actually has 5 parts, and the first part. So the lecture actually has 5 parts or sections. The first is historical aspects of the discovery of antibiotics and emergence of resistance. So with that, we'll go into a bit of history and see how antibiotics were discovered. The second part, it's on the global burden of antimicrobial resistance. So what is the burden of AMR today? Then we'll move to the third part, which is the situation of antimicrobial resistance in Ghana. So want to project what's happening in our homeland and discuss the AMR situation in Ghana. Then we'll move on to talk about ongoing interventions against antimicrobial resistance in Ghana. Finally, which is the fifth section, we will conclude and then discuss the way forward. So approximately, all of this should take about 45 minutes, and then I would end the lecture. Okay, so let's start. I think we should have the lights off for better visibility of the slides. Madam Chair, I think we should have the lights off for better visibility of the slides, because there are a lot of pictures I would want to show. I'm not able to control the slides from here. Will you be controlling it from your end, please? So I'm not able to control the slides from my laptop. It's on the slide. Okay, thank you very much. So let's start. So, as I said, the lecture will be divided into 5 sections. I think I've talked about all of this already, so I'll skip that and then go ahead. Okay, so let's start with the history of antibiotics discovery and emergence of resistance. So, historically, infectious diseases have posed one of the greatest threats to humanity, as we've just seen with the COVID-19 pandemic. However, on September the 28th, 1928, there was to be a dramatic turnaround when Alexander Fleming accidentally discovered the first antibiotic called penicillin at St. Mary's Hospital in London. And after this event, Fleming seemed to have opened the door of the golden age for the discovery of many more antibiotics, changing the fight against infectious diseases. Now, let's talk a little bit about this hero called Fleming. So Fleming was actually a Scottish physician, but then also a professor of bacteriology. This means that his work was not only focused in the clinic, but he also investigated the specimens that he collected from patients. And it is during this role as a laboratory scientist that he accidentally discovered penicillin. In fact, what happened was that he made an interesting observation involving culture plates of bacteria and fungi. And I think it would be nice to discuss what Fleming observed. But before we discuss what Fleming observed, let me take you through what happens in the bacteriology lab. So basically, what we do in the one of the major things we do in the bacteriology lab is to isolate bacteria from specimen. And to do this, we need to inoculate the specimen, whether urine, food, water, stool, or whatever, into a bacteriological medium which has nutrients to support the growth of the bacteria. After that, these agar plates are put into an incubator, and then they are kept overnight. The plates from the incubator, after about 24 hours, would have profuse growth of bacteria on them. And then you can use these bacteria colonies for any kind of investigations that you like. The essential thing is that after these bacterial cultures, they would have to be sterilized in an autoclave and discarded for obvious safety reasons. Now, it is at this point that Fleming kept the plates. Instead of sterilizing and discarding them, he kept the plates, and then he went on holidays for some weeks. Now, he returned from his holidays and observed something very, very interesting, which was to lead to the discovery of the first antibiotic. Now, what Fleming observed is the plate that you can see on the right. So, just as you leave your food, rice or whatever, on a kitchen bench for days, and come back to observe molds or fungi growing on it, Fleming came back from his holidays and observed that on the agar plate, which originally had Staphylococcus growing, you could also see fungi or molds growing on the plate. But then he observed that in the region where the fungi was growing, it was not possible for the Staphylococcus aureus to grow, or the bacteria to grow. So actually what happened was that as the fungi grew, it produced penicillin, which inhibited or killed the bacteria. Now, this observation, though very simple, was powerful as it led to the discovery of the first antibiotic that we know, penicillin. And this has opened the way for the discovery of some more antibiotics, which has helped us actually to a very large extent to defeat a lot of bacterial agents. Now, Fleming published this work in a journal called the British Journal of Experimental Pathology, as you can see. Today, that journal still exists, but they've replaced British with international. So it's now called International Journal of Experimental Pathology. So as you can see, the title of the paper is there. The author is also stated, Alexander Fleming. The institution of affiliation, St. Mary's Hospital, and the date of publication, May 10, 1929. And this is the landmark paper that, that reported Fleming's observation and led to the discovery of penicillin. Now, this is St. Mary's Hospital, where this groundbreaking research happened, as you can see there. Last year, I paid a visit to that hospital. Fleming's lab in that hospital has now been converted into a museum called the Alexander Fleming Laboratory Museum. And it's just up the staircase of that brown door that you see. Now, photography in Fleming's room is not allowed, so I couldn't take pictures. But right at the door of Fleming's lab, you see that plaque, which reads, which has an interesting information on it, which I want to read. It says, this plaque commemorates the discovery in this room of penicillin by Sir Alexander Fleming in September 1928 to the glory of God and immeasurable benefit to mankind. So this is what happened in 1928 that led to the discovery of penicillin. Now, when Fleming had discovered penicillin and had published this work, for a long time, nobody paid attention to it. And Fleming himself seemed to have abandoned any prospects of his observation being taken further. It is even reported he did an oral presentation on his work, and the chair of that meeting made some sarcastic comments saying that Fleming's observations did not carry any weight, it wasn't scientific, and there was no significance associated with it at all. And Chain had found Fleming's paper in a journal, in the journal I talked about, and they decided to take Fleming's work further. So they phoned Fleming on phone and decided to do a new investigation, looking at how to extract penicillin from the fungi, and then to purify it and to produce it in large amounts and to do testing on animals. Around the 1940s, this had been very well done, and penicillin had now entered the market as an antibiotic for use. In the year of 1945, Fleming and these two people from the University of Oxford were awarded the Nobel Prize in Physiology and Medicine for their groundbreaking research on penicillin, which was going to save a lot of lives. So this is the history of the discovery of penicillin, and I think there are a lot of lessons to learn from there. The first lesson is that I think scientists should cultivate the habit of reading, because if Florey and Chain hadn't read Fleming's paper, I'm not sure they would have found what Fleming had done to build on it to lead to the purification, production, and testing of penicillin. Now, the next slide shows a timeline for the discovery of the various antibiotics that had happened. So when Fleming discovered penicillin in 1928, he seemed to have attracted the attention of a lot of researchers now to focus work on the discovery of antibiotics. So between 1940 and 1960, there were many antibiotics that were discovered, and that helped us against the fight against infectious diseases. So you can see sulfonamides being discovered in 1935, tetracycline 1950, colistin 1959, methicillin 1960, then on and on and on. But you'd see that after the 1960s, the rate of discovery of antibiotics seemed to have slowed down, and all the way since 2014, it looks like there's been no new antibiotics that has been discovered. So that's the timeline for the discovery of antibiotics. Still on that figure, you'd also see the emergence of antibiotic resistance. So Fleming discovered penicillin in 1928. Around the 1940s, they started using it. And then not long after that, penicillin resistance emerged in 1949. And you see that has also been the situation for the various antibiotics that have been discovered. So for example, look at methicillin. It was discovered in 1960, and then in 1962, there was the emergence of resistance. And that's the situation for many of the antibiotics. So this evening's lecture is actually going to focus on antimicrobial resistance, its burden, and then the situation in Ghana, the ongoing interventions, and how to deal with this problem nationally in our country. So I think we've had a bit of the history. Now let's look at the global burden of antimicrobial resistance. Since 2013, it had been reported that annually, the number of people who die from antimicrobial resistance is about 700. So every year, about 700,000 people globally die due to antimicrobial resistance. Now, in 2019, there was a major study, actually a systematic review, that showed that the estimates we had from 2013 was a gross underestimation of the mortality rates of antimicrobial resistance. So the study in 2019 actually showed that in that year, almost 5 million people died as a result of antimicrobial resistance. Now, in 2019 was also when we had COVID-19. So COVID started in 2019, and then in 2020, it entered one of its hottest periods. And even with that, in 2020, the number of people who died from COVID was 1.8 million. 1.8 million. Now, that is about a third, about a third of the 5 million that antimicrobial resistance had killed in the year before. So if we describe COVID as a pandemic, then we can also say that antimicrobial resistance, it's a pandemic. And actually, I would call it a super pandemic. You see that the mortality rate in 2019 was almost 3 times the mortality associated with COVID. Now, in that year, those who had done the systematic review also told us that antimicrobial resistance that year in 2019 was the 3rd cause of death. I think it had only been surpassed by cardiovascular diseases and cancers. But AMR was the 3rd leading cause of death in 2019. So this shows the extent of the problem of antimicrobial resistance. It's really a pandemic that is ongoing that we need to pay attention to. Currently, the World Health Organization puts antimicrobial resistance as one of the top 10 public health threats in the world. So that shows that it's a very important issue. This slide tries to show a distribution of the burden in terms of mortality associated with antimicrobial resistance in different regions of the world. So right away, you'd see that the highest burden is borne in West Africa, unfortunately where we are, has the highest mortality rate associated with antimicrobial resistance. Following that is Eastern region. So this slide shows the regional distribution of mortality associated with antimicrobial resistance. And you'd see that unfortunately, West Africa, where we are, has the highest burden, followed by East Africa, followed by Central Africa, and then Southern Africa. And Asia comes, I think, as the 5th, and then Eastern Europe, and then it continues. Australia seems to have a very low mortality rate of antimicrobial resistance. So we see that AMR is a huge global problem, and it tends to focus more on more in Africa, especially in West Africa. Now, in Africa are also 2 big killers, malaria and then HIV. And I'm sure somebody will be curious to find out. Then, how does AMR compare with malaria and HIV? So you'd see that on the right, in that year of 2019, in Africa, the mortality associated with antimicrobial resistance was 104600, whereas for malaria, it was just 639554, almost about a half, slightly more than half of the mortality rates associated with AMR. You'd see that for HIV as well, the mortality rate doesn't come anywhere close to that for antimicrobial resistance. In fact, when you add the mortality rates in 2019 for malaria in Africa and HIV, then that now becomes a bit, now that becomes comparable to antimicrobial resistance. So if you put malaria and HIV mortality together, then that becomes comparable to the mortality of AMR, telling you that AMR is a big, big, big issue in Africa. Actually, it's a matter of life and death in Africa. The next slide tells us and gives some projection into the burden of AMR into the future. It says that by the year 2050, if the AMR problem is not tackled well, now it will lead to 10 million people dying every year. And with that, AMR is not going to be number 3. It's going to displace cancer and all the other public health threats that we know. So AMR, by 2050, if it progresses at the rate that it's doing now, is going to be the leading killer in the world. And unfortunately, the burden is going to be in 2 geographical areas, as you can see, in Africa and then in Asia. Very, very unfortunate. Let's look at the economic costs. In the year 2017, we're told that the costs associated with antimicrobial resistance is about $300 billion globally. Now, by 2050, if the problem is not tackled properly, then the cost is going to go as high as $100 trillion. $100 trillion, which is so much money. I'm sure if that money should be shared for all the people that live in the world, each person will get a significant amount. And that's how much we are going to lose to antimicrobial resistance if the problem is not properly tackled. Again, you'd see that the burden is going to be more in terms of cost economically, more in Africa and also in Asia. These are the 2 regions which already have a huge problem with finances. Now let's see how antimicrobial resistance affects the SDGs. Now, antimicrobial resistance affects about 6 of the SDGs. SDG 1, SDG 2, SDG 3, 6, 8, and 12. And this shows that antimicrobial resistance is going to threaten our achievement of these sustainable developmental goals. For example, look at SDG 1, which is to eliminate poverty. Now, if it costs more to treat a resistant infection, so if somebody living in Africa or Asia who is already poor gets a resistant infection, then the person is going to change antibiotics a couple of times, and that is going to be more expensive. So this shows that AMR threatens SDG 1, which is related to elimination of poverty. Now let's move on to this slide. So this slide shows the kinds of pathogens that are major killers as far as antimicrobial resistance is concerned. So the organism that causes the highest mortality, as you can see, is Escherichia coli, followed by Staphylococcus aureus, followed by Klebsiella pneumoniae, followed by Streptococcus pneumoniae. There's also Acinetobacter, and on and on and on. Now, actually, it's known that the first 6, which I call the big 6, are the major bacterial agents that drive mortality in antimicrobial resistance. And the sad thing is that among these big 6, we have a vaccine for only one of them, Streptococcus pneumoniae. And even with Streptococcus pneumoniae, the vaccine we have is not a perfect vaccine. So that shows how dangerous and precarious the situation of antimicrobial resistance is. Now, antimicrobial resistance is a natural phenomenon that occurs in bacteria, but then it can be hastened or accelerated by a number of things, and this slide shows what drives antimicrobial resistance. So, for example, one of the major things driving antimicrobial resistance is the high consumption of antibiotics and less prescribing appropriateness. So, as our doctors prescribe antibiotics anyhow, and people take them in large amounts, it can accelerate the problem of antimicrobial resistance. Related to that is self-medication. In Ghana, in many African countries, it's very easy to get antibiotics over the counter. And as people consume more of antibiotics, that becomes a major driver to antimicrobial resistance. We can also see substandard antibiotics which is common in many countries in the developing world. In the developed world, hardly will you find this, but here it's quite common. Many people, because of profit, want to trade in substandard antibiotics, and that is a major driver of antibiotic resistance. There's also international travel, which is causing the spread of antimicrobial resistant pathogens from one place to another. So if you have to travel from Ghana to England and you are carrying a resistant bag on your shirt, then you take it from Ghana to Heathrow, leave it there, and then from there it can disseminate. So international travel also plays. And then there's also the high rate of use of antibiotics in animal husbandry, which is also a major, major problem. So these are the major drivers of antimicrobial resistance. Actually, self-medication, the high antibiotic consumption, and the inadequate interventions relate more to a weak healthcare system as pertains to African countries. And that's one of the reasons why we have all these drivers happening, escalating the rate of antimicrobial resistance. Now let's move on to our homeland in Ghana, the situation of antimicrobial resistance in Ghana. So just before this talk, what we did was to do a PubMed search of the publications, the research that people have done on antimicrobial resistance. And it was exciting to see that you could find as many as 464 articles published on antimicrobial resistance in Ghana. In Scopus, about 417. I'm sure there's an overlap of most of the papers. Compared to a country like Sierra Leone, we found, I think, about 127 articles showing that there's a lot of work going on in Ghana on antimicrobial resistance. And I think that is a plus, because these studies would provide the information that we need to provide guidelines and policy for antimicrobial resistance. So in Ghana, as far as research is concerned, I think we have some good information. So what we have done for this talk is to try and synthesize all these articles that have been published in Ghana in a form of a systematic review. So now systematic reviews are thought to be more authoritative and provide stronger evidence than single papers that you read from authors. So what we've done is to synthesize all the data that we have in Ghana into several systematic reviews. So for describing the AMR situation in Ghana, I'll be referring most of the time to the synthesized data that we have published in this systematic review. So at least we have these 3 systematic reviews. The first one is titled Antimicrobial Resistance in Ghana from a One Health Perspective. Then we've also done another one titled Molecular Epidemiology of Antimicrobial Resistance in Ghana. Then we've also done another one titled Optimization of Antibiotic Use in West Africa. That is focused on West Africa because we didn't have enough data in Ghana to do that systematic review. So for a systematic review, you need enough data to synthesize to make your evidence credible. So I'll be referring to most of those papers to describe the situation in Ghana. So from the One Health paper that we did, on my left, you'd see the different pathogens that these studies, about 500 studies in Ghana, have reported on. I think the list is about 47, but the most common pathogen that has been studied in Ghana is E. coli. E. coli is one of the big 6 that I talked about, which drives AMR mortality. And you'd see that whether it's human studies or animal studies or environmental studies, it's still E. coli, which is the most studied organism in Ghana. Now we've tried on the right, as you can see, to provide some information on the antibiogram of E. coli. It wasn't possible to report on the antibiogram of all the organisms, so we selected that for E. coli to show. So again, you can see that whether it's in humans or animals or the environment, we find high prevalence of resistance. The upper limit, in most cases, is above 90. So you can see the resistance to ciprofloxacin peaking at 89% in Ghana in humans, peaking at 54% in animals, and lower in the environment, about 17%. So if you go through all the antibiotic, you see a high prevalence of resistance to each of these antibiotics. In fact, for antibiotics like ampicillin, which is in the middle, you see that across humans, animals, and the environment, it's reached 100%, showing that it has become a completely useless drug, which cannot be used for anything. So this highlights the situation of antimicrobial resistance using E. coli. Now, to get some more insights into the evolution of antimicrobial resistance in Ghana, how it has changed over time, what we decided to do was to compare two nationwide studies. So my department did a study in 2003. I remember at the time I was a research assistant. And then we did another nationwide study in 2014. So over the period of a decade or so, you can compare and see antibiotic by antibiotic what the story has been. So you would see that on my right, we only have data for 2014 for a number of the antibiotics, and flucloxacillin and meropenem, and a number of them. Because probably around that time, these antibiotics were not being used frequently, so they were not being tested. But apart from those, you would see that for all the other antibiotics, we have data for 2003 and 2014. You would see that, again, for each antibiotic, between 2003 and 2014, there's been some increment in resistance. So you can see that for tetracycline, very marginal, more resistance in 2014, but very small. Ampicillin as well, you can see chloramphenicol. And then look at drugs like gentamicin, cefuroxime, cefotaxime. For these drugs, over the period of 10 years, you would see that the resistance seemed to have tripled. So, for example, look at cefotaxime. It used to be a very good drug around 2003. Prevalence of resistance was about 20%, indicating that theoretically about 80% of cases will be susceptible to this drug. But see, in 2014, the resistance is now over 60-something, showing that there's been about a threefold increase in resistance for this drug. And gradually, that is how most of the antibiotics that we have are increasing in resistant prevalence and getting to that level of high antibiotic resistance. There's also some interesting data with penicillin, what Fleming discovered in 1928. You see that in penicillin, for penicillin, in 2003, the prevalence was 50%. And then, instead of moving up, like the other antibiotics, resistance seemed to have dropped significantly, which is interesting. Several things may account for this. But what it also shows is that probably, because at that time penicillin resistance was very high, people stopped, it wasn't usually being prescribed, so we stopped using it. And after 10 years, the resistance seemed to have dropped. And I think this is very interesting information. In some countries like the Netherlands, it was found that some of the drugs that they stopped using in a long time later on have showed lower prevalence of resistance. If this is true and correct, then I think this is very interesting information which may have some policy implications. Now, let's move on to, still on the One Health systematic review paper, let's move on to the prevalence of multi-drug resistance. Now, multi-drug resistance is where a bacterial pathogen becomes resistant to at least 3 different classes of antibiotics simultaneously. And that is a problem because it makes treatment very, very difficult. There are situations where we've isolated multi-drug resistant pathogens from patients, and the doctors have to struggle to find a suitable antibiotic. And in some of these cases, the patient died because it was not just possible to find a suitable antibiotic because the organism was multi-drug resistant. So multi-drug resistance is very important and it's something that we need to pay attention to. Now in Ghana, this is a picture for multi-drug resistance from the systematic review that we did. So again, you'd see that multi-drug resistance looks very high. So look at an organism like Escherichia coli, which is the leading cause of death, according to the global data that we showed. Its MDR in humans has reached 99.6, almost 100%, very, very high. We see that also for animal studies. Some studies reporting 100%. So MDR is also a very big problem in Ghana, as you can see from the data across all the sectors of human, animals, and the environment. Now, furthermore, there are pathogens we call superbugs. So these are also multi-drug resistant organisms, but they are extremely resistant to antibiotics. And one thing about them is that they can spread very fast and they are prone to causing outbreaks in hospital settings and in the community. So we also try to see the occurrence of these superbugs in Ghana. Again, you can see that we have high prevalence of some of these superbugs. ESBL producing E. coli has reached about 83.9%, and so on and so forth. So putting the last slide and this slide together, we can tell it gives a picture of the problem and the burden of antimicrobial resistance. We have high prevalence to some antibiotics like we saw, coupled with multi-drug resistant organisms and the spread of superbugs in the country. Now, what we've done is to select one of the superbugs and to try to monitor its occurrence in Ghana over a period of time. Again, still from all the data that we have in Ghana. So you would see that for this superbug called methicillin-resistant Staphylococcus aureus, its prevalence seemed to be going up generally from 2016. So before 2016, it was still there with high prevalence in 2012 and so on. But after 2016, generally, you can see that it seemed to be moving up. And interestingly, in 2012, when we saw, so in the graph that I showed, in 2012, there was a high prevalence. Interestingly, around that year, there was an outbreak of MRSA at the children's ward, the emergency ward at the Kolebu Teaching Hospital, which was carried by the Daily Graphic, which said Kolebu Children's Emergency Ward closed. And in that outbreak, 3 children died. And around that time, there were a number of reports of this superbug in different parts of the hospital. Now, in that outbreak, what we did was to try to investigate the outbreak using whole genome sequencing. So what we did was to collect samples, environmental samples, samples from doctors, nurses, hospital visitors, from tables and all of that. And using whole genome sequencing, we were able to reconstruct what may have happened in the ward that led to the outbreak. So our investigation actually showed that somebody picked the nose and deposited, so Staphylococcus aureus lives as a normal flora in the anterior nose in the nose. So you can be picking your nose and be distributing Staphylococcus aureus. So we realized from the whole genome sequencing that somebody had picked the nose, left the organism, which was a particular strain called ST15, on the door handle of the emergency ward. And that emergency ward, unfortunately, has only just one door. So the ST15 MRSA on the door handle then became a source of distribution within the ward. So that was a single door handle that everybody was using. So the doctors, the nurses. So furthermore, we saw that this ST15 was also found on the baby's cot, also found in also found on a table in the hospital. So that's what happened with the outbreak, where somebody picked the nose, left the organism on the door handle, and then the door handle became the source of contamination in the hospital. And this bag kept circulating in the hospital, in the ward, eventually resulting in the death of 3 children. Now that shows us the power of this tool called genomics, which is giving a lot of insight into how bacterial pathogens behave. So using genomics, we've been able to, different studies have been able to map out the different clones of MRSA that happens, that are occurring in Ghana, and which regions in Ghana these clones can be found. So again, we try to synthesize all the data on MRSA in Ghana together. Then you'd see that we have clones like ST8, ST88, ST152, ST83, and this map shows their geographical distribution in Ghana. Some of the clones are in red. They are in red because in other countries, they've been reported to be epidemic clones, causing outbreaks in hospitals and in communities. So for example, we see ST8, ST88, and being some of the epidemic clones that we have in Ghana. Interestingly, one paper had shown by whole genome sequencing that the ST8 had actually been imported from the Netherlands into Ghana. So when we showed the slide on the drivers of resistance, we showed that air travel is one of the ways by which AMR can be spread. And one paper had showed that ST8 had actually been imported probably from the Netherlands into Ghana as a result of international travel. Now this slide shows the antibiotic genes that we have circulating in Ghana. So again, this is also developed from a systematic review, synthesizing all the data that we have in Ghana. So you see a large population of antibiotic genes which are being distributed in the environment among animals and humans, and these are driving antibiotic resistance. So you'd see that a few genes are shared by both animals, humans, and the environment. And though there are many genes, there are just about 2 or so which are shared among animal studies, humans, and the environment. And this provides very useful information for surveillance of antimicrobial resistance. Now, we've said that one of the drivers of antibiotic resistance is the consumption of antibiotics. Before that, let's talk about antibiotic prescribing appropriateness. So one of the things that drive antibiotic resistance is the consumption of antibiotics. And we've tried to see the appropriateness of prescribing by our medical officers to tell whether it's good or not, and whether that contributes significantly to antibiotic resistance. So you'd see that in Ghana, it looks like the prescribing appropriateness looks very good. So there was one study which showed that the prescribing appropriateness was over 90%. Another study showed that it was over 80-something%. So generally in Ghana, it looks like the prescribing appropriateness appears to be good. There's just one study which showed a very low prevalence. Now the question is whether this is a situation for all the hospitals in Ghana. Since this is a systematic review, we just synthesized the data that was available. But as to whether this nice picture of prescribing appropriateness that we see pertains to all the hospitals in Ghana is another issue. We've tried to compare that with other countries like Sierra Leone, Nigeria, Liberia, And again, you can see that Ghana appears to be high up there. So it shows that we are not doing too badly. Now, this is a slide also from the systematic review that shows the consumption of antibiotics in Ghana. Again, you can see that some of the drugs have very high consumption rates, while others have low consumption rates. But this shows the picture of the volumes of antibiotics that the people consume in Ghana. Linked to that is the rate of antibiotic use in animal husbandry. So it's known that in veterinary medicine, a lot of antibiotics are used. Apart from that, animal farmers also use a lot of antibiotics in order to get the animals healthy and all of that. So this is some original research that we did many years ago, and you can see that there's a high rate of antibiotics used in poultry, where about over 70% of farmers every week use antibiotics on their poultry, right? So this is a major driver of antibiotic resistance. Now, to the right of that slide shows how the meat and the beef and all of that that we consume get contaminated with antibiotic residues from the high usage of antibiotics that our poultry farmers and other animal farmers are using. So again, you'd see the proportion of samples that are positive being quite high. So it looks like we can see the different animal food samples, but then on the right, you see the contamination rate. So I think the first one is milk. This is the raw milk from cattle, which is usually sold by the Fulani people. So about 35% of that is contaminated with antibiotic residues. We also see 30.8, I think that is beef. We see 29.3, we see 24. We see a relatively low prevalence for eggs. I think that's 6.8, probably because of the protection that the shell provides, not allowing antibiotics to penetrate into the interior of the egg. But generally, what this shows is that the high use of antibiotics in poultry and animal husbandry in veterinary medicine gets these antibiotics translocated into the animal source that we use as food, beef, pork, and all of that. This slide also shows how antibiotics are misused, actually, in the community with regard to community pharmacies. So there was a study that we did among pharmacies in Accra, and we see clearly that a lot of people can acquire antibiotics over the counter without any prescription. And that leads to the next slide, which shows a high prevalence of self-medication, because if you can get antibiotics over the counter without a prescription from a doctor, then that is going to lead to high rates of self-medication. So we did a study to find out the prevalence of self-medication among tertiary level students, and the results looked alarming. 70% of them are practicing self-medication, and we've seen that that is a major driver of resistance. Most of the people practicing self-medication cited two reasons. The fact that it was less expensive, so they thought, if it's less expensive, then why don't I go to the pharmacy and get myself some antibiotics? Then a lot of people also talked about the long delays in hospitals. So if I was sitting in the hospital for hours and I can self-medicate, get antibiotics without prescription, why not? So these are some of the factors driving self-medication, which in itself is a major driver of antimicrobial resistance. So we've seen the picture in Ghana. We will now talk a little bit about the ongoing interventions against antimicrobial resistance in Ghana. Now the first is what we call the National action plan against antimicrobial resistance. So around 2016, there was a global action plan which asked all countries to try and develop a national action plan for antimicrobial resistance. So far, many countries have still not done that, but in Ghana, we were able to do that, and this document was launched by our president on April the 11th, 2018. And this plan shows clearly how we're going to tackle antimicrobial resistance in Ghana. Now, the other intervention I want to talk about is the National Surveillance of Antimicrobial Resistance funded by the Fleming Fund. So, to solve the problem of antimicrobial resistance, the UK government decided to make available £250 million to solve the problem. And this was going to be a big investment in developing countries to solve that problem. And this money was given to different countries. And in Ghana, we got some of them. I think the first one was about £1.8 million. And then recently, the Fleming Fund has also decided to give $3 million to undertake surveillance of antimicrobial resistance, which is one of the needs that we need to address to solve the problem of AMR. So this study started not too long, and it's led by Dr. QUAKYI of the Orum Institute. And here we see clearly what they plan to do with this grant. So this grant actually has several outcomes, 4 main outcomes. The first one is quality AMR, AMU embedding data that will be produced. The second outcome is the quality data analysis that will be conducted. The third one is the quality data analysis shared with decision makers. Then finally, they'll also be promoting sustainable investment to counter antimicrobial resistance. So for this work, they have £3 million to do this work. And they are working with a number of sentinel sites in Ghana, and also with the Department of Medical Microbiology in the medical school, my department, which serves now as the National Reference Antimicrobial Resistance Lab. So we expect to generate a lot of data through this grant, working with Orum Institute to see how we can address the problem of antimicrobial resistance. Now, the second ongoing intervention that we have, which I want to talk about, it's about capacity building. Capacity building. So we also have a grant from the National Institute of Health for 5 years, and that is to help us train people, PhDs and postdocs, specifically on antimicrobial resistance. So we are running a program which focuses entirely on antimicrobial resistance, and these PhD students and postdoc students are doing high-level research in antimicrobial resistance. And we hope that as we build capacity in this area, the trainings that we get would be able to tackle the problem of AMR. This training is not only limited to Ghana, it's a sub-regional training. You'd remember from the slide I showed that the highest burden of antimicrobial resistance globally happens in West Africa, right? So this training is across all the West African countries to make sure that we have trained people who will fight against AMR. Another ongoing intervention is about drug discovery. So from the timelines of antibiotic discovery that I showed, you'd realize that after 2014, there's not been the discovery of any major antibiotic, while at the same time, antimicrobial resistance appears to be climbing up. Now, for most places now, they have, most scientists have resorted to natural products, trying to find plant extracts, which may be able to help kill these pathogens like E. coli, Staphylococcus aureus, Kleb pneumo, and Strep pneumo. So again, we did a systematic review to find out the prospects of using natural products. And this is a table that shows plant extracts working against one of the big 6 pathogens that I talked about. So these are plant extracts against Klebsiella pneumoniae. And you can see that we have some positive results for some of the plant extracts, showing that probably this can be an area that we can focus on to find out our herbs and plants which can have some antibacterial activity against the multi-drug resistant bacteria that we know. In connection with this, it's exciting to know that the government has established the Center for Scientific Research into Plant Medicine, which is doing a lot of this work. In our department, we also have a big grant from the African Development Bank and trying to set up some of these studies on natural products, which is being led by Professor Kwame Natsego and Professor Dei and others. Okay, so this is still on the drug discovery, trying to show how plant extracts can show activity against some of the multi-drug resistant bacteria that we know. So for example, look at the first plant there. We see very positive results. So it shows clearly that some of the herbs that we have can be targets for further research to see how we can leverage on these to tackle antimicrobial resistance. Another ongoing intervention against antimicrobial resistance is the use of bacteriophage therapy. So again, this is another review that we have done to find out how people have successfully used bacteriophage to treat some infections. So bacteriophage are actually viruses which can lyse bacteria, which can kill bacteria. And they've been used in combination with antibiotics in different places to see how that can be used to treat AMR. In Ghana, we've also just started a collaboration in my team, working with colleagues at the University of Sheffield and trying to see how we can use bacteriophage to treat diabetic foot ulcers. So that's a project that we have just started, and it's running for about 3 years. And if we are successful, then this would be a very good thing to use bacteriophage to treat, the foot ulcers that we have. Another way to control antimicrobial resistance is vaccination. So with vaccination, we're able to prevent infections. So if the bug is a super bug or whatever, since we have a vaccine against it, then we can go to sleep. So here we also have a major project. So you'd recall that the big 6 pathogens I talked about, one of them was Streptococcus pneumoniae. And actually among the big 6, there's only one organism which has a vaccine, and that's Strep pneumo. Streptococcus pneumoniae hasn't got a perfect vaccine, and therefore there's a need to look for a better vaccine. We have some support from the National Institute of Health of the United States to do a study called the Pneumo-6 study. So in that study, we've collected huge samples of Streptococcus pneumoniae, over 10,000 samples, and that gives us the opportunity to screen all of these isolates to see whether we can find a surface protein, which is probably conserved in all the isolates, which will elicit a strong immune response. So that's a vaccine project that we are doing, trying to see whether we'll find some novel vaccine candidates against Strep pneumo. So these are the major ongoing interventions against AMR in Ghana, from surveillance to capacity building to trying alternative treatment methods with plant extracts, with phages, and then with also the ambitious project to see whether we can find a vaccine. So I think it's time to conclude. And you will agree with me from the slides that I showed that the highest burden of antimicrobial resistance occurs, unfortunately, in the West African region. And Ghana appears to be a hotspot for antimicrobial resistance, looking at all the prevalence that we saw with different antibiotics, the distribution of superbugs, and the prevalence, high prevalence of multi-drug resistance. However, we have made a lot of progress in tackling AMR. Why? One, we've been able to do a lot of research. I showed you the 500 papers that Ghanaian scientists had published, providing information for us to tackle the problem. Apart from that, we've also had money from donors. I'm sure we've received, from Fleming Fund alone, this may be about $4 million to set up surveillance against antimicrobial resistance. So we've made a lot of progress. We've also been able to launch the National Action Plan, which many countries are still struggling to launch. So therefore, we've made some progress. However, we need more effort because as we've seen, the burden of AMR is enormous and is projected to be very, very high in 2015, being the leading cause of death in the world. So we can't rest on our oars, but we need to do more. Now the way forward, we have the National Action Plan, which clearly addresses the needs of antimicrobial resistance. All we have to do is to try and implement them. So there's a need for more commitment from government and all of us to be able to strengthen the National Action Plan to help implement the targets and monitor the use of antibiotics at the national level, including indicators to assess progress. So we need to make sure that the National Action Plan is being implemented to the letter. We also need better surveillance of antimicrobial resistance and antimicrobial consumption. So you would see that the systematic review that we published on antibiotic use, we couldn't limit it to Ghana because there were just 3 or so papers from Ghana. So we had to widen the scope to West Africa. So there's still very, very limited data on antibiotic use. I'm sure this is a good area to try to write a grant on. There's also the need to improve the health and welfare of food-producing animals. So we saw how over 70% of poultry farmers were using antibiotics every week. Why? Because they have to assure themselves that the animals are safe and not sick. So if we have better welfare, if we improve the health and welfare of animals and animals are healthy, the farmers wouldn't have a cost to use antibiotics like we saw. It's also important to raise awareness about the problem of antimicrobial resistance. I think one of the major things lacking is advocacy. So we didn't see that in any of the papers that were published in the systematic review. And I think that that is a gap that we have to address. Advocacy to raise awareness among the public and professionals working in the human health and veterinary sectors, including training for health professionals and communication campaigns about antimicrobial resistance. So I think I'll end here. There's a slide which says, "Thanks for listening to me. Jesus loves you." Thank you.
Can we give another round of applause for this exhausting, really? So our good professor, this has been quite well worth the wait. And he's been number of months and years of waiting for this, but I think it was worth it. Congratulations again. This is wonderful. But can you imagine trying to summarize all of this? It's near impossible. But I will attempt to pick up a few salient points. I think at least the 5 major pillars: the history, the global burden, the situation in Ghana, the ongoing intervention, and the way forward, especially the very important areas where he says advocacy, awareness, all that. So historically, it tells us that scientists, we should do more reading and more observation. Fleming did take a vacation, but at least he was reading, and that discovery led to groundbreaking, global content. But the interesting thing is that after this discovery, very little was done until 1940, 1960, that the need for use of antibiotics, and I think its importance in surgery and infections became, relevant. And I think the world wars also opened up the use of antibiotics. So, but between 1940 and 1970, after that there was a death. And then resistance. I mean, if you push nature, it will change. And this is what, we're pushing antibiotics, we're pushing that, so there was change. And then he looked at the burden. Can you imagine? I really thought malaria was up there until I heard Professor SAMPANE-DONKOR. You're trying to challenge me here. But 700,000 deaths per year. And we're looking at, if we don't do anything 2050, we're looking at millions and trillions. I mean, that is quite frightening. And then in 2019, there was 5 million, surpassing COVID. I thought COVID was bad enough, but 5 million and COVID was 1.3. So really, we have a pandemic on our hands, and we're really not taking things seriously. So his research really is fundamental. And to the extent that WHO, antibiotic resistant, microbial resistance is one of the top 10 threats. It's life or death, actually. So today's lecture, if we're not aware, should really make Ghanaians sit up. And West Africa is really one of the highest, then Eastern region. So we're high, but it's not nice knowing that West Africa, we're so high in the burden. And combine malaria, HIV, when you combine the mortality of malaria, HIV, before it equates to the burden of antimicrobial resistance. Now that is really quite frightening. And then he discussed the economic costs. And the economic costs at 2050 could be 100 trillion if we don't do anything. And really its impact on the SDGs. We're so busy talking about SDGs, but it takes one organism to really run rampant. SDG 1, 2, 3. I mean, it's throwing away poverty. I mean, very soon. I mean, if you don't have money and you can't treat yourself and you're dying, how can you stop poverty? So SDGs 1, 2, 3, 6, 8, 12. Now that is an eye-opener. We've got a lot of work to do. And then the pathogens, friend E. coli, Staphylococcus aureus. And I like the bit about picking your nose. We don't often appreciate the resistance. And currently, there's some vaccine, but there are a number of risk factors or factors driving resistance. Indiscriminate prescription. I mean, many of us just would rather not go and queue up and get prescription and just go and say that we want penicillin, we want Cipro, and I think we are all subject to this. And substandard and fake antibiotics. I mean, in malaria we talk about fake antibiotics. When one study showed that in 1 year, 40% of all antibiotics in Ghana were fake. Now that tells you the impact of the death in malaria. And if that is happening in antibiotics, then it's really quite frightening. And then self-medication, we all do that, and indiscriminate prescription. But it's good to know that apparently our doctors are doing better than most people. We're not, indiscriminate prescribing too badly. Then we get on the amount of resistance, then the burden in Ghana. And it's good to know there's so much research going on. 464 articles, and then his systematic reviews, and then the multi-drug resistance. And this is where things get really bad. You're not resistant to just one, but 2, 3, to the extent that you then develop superbugs. So not only do you have prevalence, you have multi-drug resistance, you have superbug, and very soon, you're lost to to treat any disease. And I like the bit of detective work that went into, so they took one superbug and followed it through, so that the power of genomics, that you can follow, their research is so fundamental. Going through the genes, how many genes are there, and following one gene, and detective work of the ST15 from a door, from the nose to the door to emergency, and then to the whole hospital. So it tells us. We thought COVID made us aware of washing hands. But this, if nothing makes us aware of washing hands, I think this should make us wash our hands and noses and everything. But clearly, washing of hands and noses, I have to add noses. And then the importation of these gene types, as much as, we're so friendly. We take it from anywhere, from Netherlands, so when you're traveling, you have to be careful. Really, it's frightening. I think I'm going to wear my mask wherever I'm going to travel or not. But that's my personal. And then, the antibiotics genes. And then the exchange of genes between humans, environment, and animals. And then, the misuse. This was so exhaustive that I cannot say more than thank you for setting us going. And the big thing is that all the intervention that is going on, the training, the capacity, I think the most important thing is the surveillance. And you're actually, the grants. These people are talking $18 million, 76 million euros. These are, numbers that I thought I was getting grants, but this beats everything. And so they're getting a lot of grants to do the needy. Building capacity. We need the depth of capacity to sit at the table and discuss so that we're not told what to do. We need to be able to know what we're saying, what we're giving away, and what we're taking. So the point that they're getting money, building capacity, PhDs, postdocs, fantastic. And then the drug discovery. This is another area. We're sitting here and people just come and take our things away. So we have a center of excellence in plant discovery, natural products. This is a way to go. But we need to build capacity all around to do this. And then new areas of the plant extracts, the exciting area of bacteriophage therapy, and ultimately, of course, what can I say, vaccination, and the challenges of vaccination and getting the critical, component that will resist resistance. So in all, this has been a fantastic, and then finally, the advocacy, awareness, training, and training, and capacity and awareness. So again, thank you so much for a wonderful, wonderful lecture. Another round of applause. Thank you.
Right. I think we would all agree that our chairperson has summarized, and she deserves a round of applause. Right. Right. I'm informed that some colleagues and the family of Professor SAMPANE-DONKOR would like to make a presentation. So you are welcome. Yeah. Right. So while we're waiting, we would like to acknowledge all of us here making time to be present for this exciting and also a subject of critical importance, health, national development, and global health in general. I cast my eyes around and we can see a number of colleagues, senior colleagues, officials from the university, senior fellows of the academy. We don't have a list, so the risk will be mentioning one name and leaving out the others who say we are all welcome and we are all duly recognized. There are a number of schools, and we can see you are our prized audience. And the schools are Accra Academy Senior High School, Accra Girls Senior High School, Ganata Senior High School. And then we have the Accra College of Education and students from the University of Ghana Medical School. All right. So, Professor SAMPANE-DONKOR, our speaker, would very much like to express profound gratitude to the following for making this lecture a success: the Almighty God for his support, all aspects of our speaker's life, the Fleming Fund West Africa Office, and the Aurum Institute Ghana for providing sponsorship for the lecture, the University of Ghana College of Health Sciences Medical School Department of Medical Microbiology for providing an enabling environment for Professor Eric SAMPANE-DONKOR's research, the Deeper Life Campus Fellowship for providing a spiritual and uplifting fellowship to Professor Eric SAMPANE-DONKOR, and the wife and children of Professor Eric SAMPANE-DONKOR for their encouragement, inspiration, and a lifelong support system for achievement of excellence. All right, so you are welcome to make the presentation.
Proudly presented to Professor Eric SAMPANE-DONKOR, a distinguished leader and trailblazer in the field of AMR. Throughout an illustrious career spanning decades, you have made profound and groundbreaking contributions. Yes, please. That have revolutionized our understanding of AMR and shaped the way we combat this global health challenge. We extend our heartfelt congratulations and deepest gratitude to you, Professor Eric Sampane-Donkoor, for your remarkable contributions and efforts. Thank you. Please, this is from the Zoo DS.
Right. We understand there is one more presentation. You are welcome to make the presentation, and then I think that will be all right. Yeah. Thank you. Thank you very much. Announcements. So, upcoming events of the Ghana Academy of Arts and Sciences. We invite you all after today's exciting lecture to be present for 4 lectures which are coming on within the next month. The first one is the annual lecture in the Humanities 2024. Professor Amadi Graf Akins will deliver the annual lecture in Humanities on the 2nd of May 2024 on the topic, Food is Medicine, Food is Poison, a social psychological perspective on Ghana's public health nutrition crisis. Then on the 16th of May, Professor Opanyin Kofi Ejekum will deliver the Ephraim Amu Memorial Lecture on the topic Culture, Language and Music, Reliable Tools for Sustainable National Identity, Cultural Decolonization and Development. Then there are 2 inaugural lectures. Professor Samuel Jesse Obin will deliver his inaugural lecture on the 20th of May on the topic Language and Liberty in Ghanaian Political Discourse. Then Professor Kwesi Ampene will deliver his inaugural lecture on the 30th of May on the topic Performing Petition, Kete Songs, Lineage and Kinship in Akan. As mentioned, we invite you all to attend these inaugural lectures as they promise to be very interesting. Refreshments. Refreshments will be served near the car park outside the auditorium after recession. And we are also to be informed that students present, you have your refreshments package and made available to you so that you can set off in good time to get back to your campus. This brings us all too soon to the end of this exciting program. We have had a lecture invigorating on prioritizing antimicrobial resistance needs in Ghana, a national choice between life and death. Professor Sampane-Donkor's inaugural lecture at the University of Ghana was also on the 130 years war. So Professor Sampane-Donkor is a warrior, a Ghanaian warrior, leading the charge against infectious diseases and bacterial pathogens. On this note, I think we've come to the end of the program, and I kindly, respectfully ask us all to stand as the speaker and the chair recede from the program. Thank you.
it's glorious. Oh, and as you feel the notes build, oh, you will see. It's like a symphony. Just keep listening, and pretty soon you'll start to figure out your part. Everyone plays a piece, and there are melodies in each one of us. Oh, it's glorious. It's glorious. Oh, it's glorious. About you took the fall.